Okay, welcome back, everybody. I hope you had a nice lunch. Just a couple of items before we get started. We'd like to ask people to please use the microphones when they ask questions, and I think we've just organized to have the microphones passed to people. So just wait for the mic to come to you. And when we do the poster presentation, we're going to ask the speakers to come up here and sit. And they'll each in turn give their presentations. And was there anything else? And we're starting a little bit late, we're running a little bit late, but we'll recoup time with the break. So we won't ask you to stay late today. Okay, so now without further ado, it's really my pleasure to introduce Dr. Grant Iverson. We're really lucky to have him here. Dr. Iverson, where is he? Was in the room a moment ago. He probably doesn't need to hear his own bio. So Dr. Iverson actually left from Canada to the US a couple of years ago in 2013. And he's now a professor at the Department of Physical Medicine and Rehab at Harvard University. And there he is. He's taken over the directorship of the Mass General Hospital Children's Sports Concussion Program, and he's also the associate director of the Traumatic Brain Injury Program for Home Base, which is a Red Sox foundation at Mass General. Grant has been a leader in the international consensus conferences, and I didn't mention that he's a clinician scientist. And he's been a very prolific publisher. He's published more than 33 empirical articles, reviews, and chapters. And as I say, we're really delighted to have him here.
I am delighted to be here today. The weather is fantastic in Toronto this time of year. It's balmy and lovely. This conference has been interesting and stimulating. I've really enjoyed it. I'm pretty sure this is my first year here, and I think you've done a wonderful job putting this together, and it's a great lineup of topics. By way of disclosures, we have received research funds from a variety of sources over many years. I spent a big chunk of my career at UBC, as you know, so you see some drug companies from Canada. Probably the disclosure most relevant to this talk would be Impact. Impact has given us a philanthropic donation, an unrestricted donation for research. And that's probably the most important to alert you to. Sorry, I'm having trouble with the button here. Oh, it helps if you hold it right side up. The arrows don't help you so much, but the direction of the device does. So, other disclosures. I receive royalties from books and neuropsychological tests. I have a small independent practice in forensic neuropsychology that includes expert testimony. I occasionally receive honorariums for travel. So, on with the topic. Sport-related concussions. These injuries, the pendulum has swung a few times over the last 25 years on these injuries. But these injuries, we now know, have a very large adverse effect, acute effect, on cognition, balance, and self-reported symptoms. What I'm talking about today is clinical recovery from concussion, as you'll see. So these injuries have a large acute adverse effect. These are meta-analytic effect sizes, so aggregated effect sizes from the literature on the overall adverse effect of concussion, sport-related concussion, on cognition in the first 24 hours. You see it's about a full standard deviation. Those are Z-scores, or for you Canadians, Z-scores. I'm bilingual. That's one standard deviation below the mean. And you can see that An effect size of 0.84 is what you would expect on average for individuals who have had a moderate to severe traumatic brain injury after 2 years of recovery time. And an effect size of about 1 standard deviation is early dementia. So you can see it's a large overall, in group studies, adverse effect. Some have a very small effect, some have a very large effect, because this is the average. Now, what about the effect on symptoms and balance? These effect sizes are a little bit skewed by methodology. Many of the studies that have examined symptoms and balance occur more acutely than the studies that examine cognition. By that, I mean they examine the athlete rinkside or sideline versus sometime within the first 24 hours. So part of what you're seeing with these massive effect sizes for symptoms and balance is an artifact of methodology. But nonetheless, when you do a head-to-head comparison of these 3 modalities, cognition, symptoms, and balance, being assessed during the same time period, symptoms and balance are still much greater than cognition. Fortunately, we think and hope the brain is undergoing a dynamic restoration so that these effect sizes drop dramatically over the first week and certainly over the first 3 months following injury. So when we think about clinical recovery from sport-related concussions, I'm talking only about sport-related concussion today, not civilian mild TBI, not injuries in the military, not the overlap of multiple neurotrauma, blast exposures, and PTSD and depression and substance abuse in veterans. I'm talking only about sport-related concussion, multiple sport-related concussion, and most of this talk is focused on youth. For most athletes, the cognitive deficits, the balance problems, and the symptoms improve rapidly over the first week and certainly over the second week following this injury. There's a large number of studies, if you go back 20 years, a large number of studies suggesting that most athletes recover in about 10 days. Now, part of that is an artifact of methodology because we are obsessed with group stats. So we tend to lump everyone together. We tend to assess them at different time points, and if they show that trend toward recovery and those means are dropping, we tend to say they've recovered by that certain point in time, but rarely have people examined individuals within the group to determine what is the variability at that last time point. But increasingly over the last few years, more of that type of work has been done. So you're going to realize now, most of you already know this, but in the last few years, more and more studies are pointing out that many athletes, a sizable minority, require much longer than 10 days to clinically recover from this injury. If you aggregate the literature right now, as of January of 2017, I would say it's safe to say that the vast majority of athletes who sustain a sport-related concussion will recover from a clinical perspective within 30 days, the vast majority. But there's caveats, as you'll see to that. The biggest caveat depends on how you sample people. I work in a slow-to-recover clinic. So at Mass General for Children, virtually every single patient that we see, every youth, every adolescent, every high school student, every college student, almost all of them are beyond 30 days. So if we were doing research in our clinic, we would say, oh my gosh, it's an epidemic of slow-to-recover youth. No one recovers, but of course we're not seeing the ones that do. We're not seeing the ones in America. Pediatrics is primary care, as you know, so you show up in your pediatrician's office a day or two after injury, 5 or 6 days later you're feeling great. The next week you're really feeling well and you've carried on with your life. We don't see those folks in our clinic. How can you predict whether someone is going to clinically recover or not? Now, I'm a broken record on this clinical recovery term. We don't know what's going on in your brain. We don't know the extent to which physiological recovery coincides with clinical recovery. We assume that a lot of it does. It makes total sense, because if you look after athletes who are acutely injured, they are really sick in the first 2 or 3 days. They're miserable and sick, and then they feel better over time. And it makes a lot of sense that their physiological recovery is paralleling their clinical recovery. But we have ample evidence now, reasonable evidence from multiple sources, that physiological recovery might take longer and might be incomplete following this injury. We have that in electrophysiology. And you're seeing some of that data here today, EEG and evoked potential work. We have that in neurometabolism, in MRS studies. That's where the data is probably the most popular amongst the sports med community. And we're starting to see more of that in the realm of diffusion tensor imaging, although we don't know how to interpret that data. That data has been very challenging to figure out what does it mean when you're seeing DTI changes well beyond clinical recovery. But nonetheless, for the purposes of this talk, I'm only talking about clinical recovery, not physiological recovery. What are some of the candidate predictors or correlates or modifiers of recovery? They're on this slide. You can see these are ones that you've all been thinking about for years: sex differences, age differences, genetics, whether you have ADHD or not, whether you have a personal or family history of mental health, of course, how many injuries you've had in the past. Then, of course, we've been interested for a long time in whether injury severity characteristics predict recovery time, like whether you had a loss of consciousness or some degree of post-traumatic amnesia. And increasingly, and probably most importantly, some of these initial post-injury findings, as you'll see some data in a moment, initial post-injury findings might be the most potent predictors of clinical recovery time. So we have conducted, a group of us, a review of the entire world literature on this topic. And that review will be published in the next few months in the British Journal of Sports Medicine as part of the Concussion in Sport group review of all the literature and ultimately our consensus statement. For this review, we were interested in the so-called modifiers, but we're more interested in predictors. A predictor of outcome versus a modifier of outcome, that you can have a modifier being an effect modifier. If you think about a disease model and you think about whether a variable influences from exposure to disease, has some influence on the course of that disease, or whether you get that disease, that can be some kind of effect modification or an intermediary variable or a confounding variable. We looked at all of that for the purposes of this review and looked at thousands and thousands of papers to try to identify anything that's ever been published in the literature having to do with clinical recovery. And we defined clinical recovery as basically a return to normal functioning. Return to school, return to sports, return to normal cognition, return to, you're asymptomatic, that sort of thing. Now, when you think about this literature, I think it's important for you to appreciate that there are enormous methodological differences across studies, across countries, within countries, across research groups doing the same thing. There's all kinds of differences in outcome variables, in the time between the injury and when the outcome was measured, in the settings in which the work was done, in the number of variables examined. So many studies looked at a single variable, like, is there a sex difference? And some studies will look at dozens of variables, and it makes a difference in what you're going to find. There are other important considerations before you get the concise summary of the world literature on predictors. Think about other important variables. One, think about how people conceptualize, experience, and report symptoms prior to injury. That may or may not be a predictor, a clinical predictor of outcome, but it's an important variable. It's their worldview. So, girls and young women, if you give them a questionnaire, on average, they endorse more symptoms, they more freely report symptoms than boys and young men. Athletes with a history of ADHD or learning disabilities endorse more symptoms at baseline than athletes who don't have a developmental condition. Individuals who have a personal history of treatment for substance abuse or mental health or migraine endorse more symptoms at baseline. Individuals who have prior concussions endorse more symptoms at baseline before they're injured the next time. And then there's all these variables that we don't know about, but we know are important. Life stress, terrible sleep, that sort of thing. That can influence how people conceptualize and report their symptoms at any point before or after an injury. I'll show you some data on that. Here's some high school students. This was published last year. This is a study in which we were curious about how high school students would report symptoms if you gave them a post-concussion questionnaire, but they had no injury. So baseline testing, do your baseline cognitive testing and fill out your symptom questionnaire at baseline. We then said, well, let's just determine how many high school kids meet criteria for the ICD-10 post-concussion syndrome in the absence of head trauma. So we say, all right, in order to meet the criteria, here's the criteria. We're not measuring excessive worry over symptoms or intolerance for alcohol, so we'll just stick with physical, emotional, cognitive, and sleep. The database has about 33,000 high school kids from the state of Maine. They're between the ages of 13 and 18. Some of these were actually middle school kids. None of these children reported a concussion in the prior 6 months. The criteria for the syndrome that we used for this study was you have to endorse symptoms in at least 3 out of 4 symptom domains. So you had to endorse at least one physical symptom, cognitive symptom, emotional symptom, or sleep symptom. You had to endorse at least 3 out of 4 of those domains, say, yes, I currently am experiencing those symptoms. And these are examples, because this is a stock standard post-concussion syndrome questionnaire. These are examples of the symptoms that we were asking them about prior to the season. So, in order for us to flag you as having the syndrome, 3 out of 4 domains you had to have symptoms. So, what percentage of high school boys and girls in the state of Maine have a post-concussion syndrome in the absence of head trauma is the question. 1 out of 5 boys and 28% of girls. So this is baseline. Now, all this means is that these young people on a questionnaire are endorsing some level of mild symptoms. So have you felt irritable? Have you felt tired? I don't know, has anyone felt irritable in the last 2 weeks? Anyone felt tired? Anyone have difficulty concentrating? Not just the last 5 minutes, but so we know that these are normal symptoms, and we also know that these symptoms, at least a subgroup of these symptoms, get ratcheted up dramatically when you get injured, and then they fade over time, and then some become entrenched and persistent. But let's look at some characteristics of students that are associated with greater symptom reporting. So, children, boys in yellow, girls in gray. Girls across the board are endorsing more symptoms than boys. Youth with ADHD endorse a pattern of symptoms suggestive of a post-concussion syndrome in the absence of head trauma. And those with prior mental health and substance abuse treatment, they endorse a lot of these symptoms. I consider these sort of general distress symptoms. Symptoms like you feel irritable, you have trouble concentrating, you get some headaches, you have fatigue, your sleep is messed up. These are common symptoms that are more common in individuals who have a premorbidity or a comorbidity, some kind of developmental or mental health problem. What about concussion history? So, children and adolescents who have a history of prior concussions endorse more of these symptoms at baseline than children who don't have a history of prior concussions. For this same article, we put all of these factors into a multivariate analysis because we wanted to know to what degree do prior concussions predict these symptoms after controlling for other variables like ADHD, academic problems, LD, mental health history, substance abuse history, migraine history, or personal history of headache. We put all those variables into a multivariable model, and prior concussions were still independently related to symptom reporting at baseline. Interestingly, they happen to be the smallest predictor of all the variables in the model. So things like headache history, migraine history, mental health history, and ADHD were stronger predictors of whether you were going to endorse symptoms than concussion history, but everything was significant in the model. What we didn't put in the model that we've analyzed separately is the role of sleep, because in that particular model, we were interested in health history variables like comorbidities or premorbidities. We were not interested in situational factors, but look at the role of sleep on concussion-like symptoms. The total sample has 19% of boys and 28% of girls who meet criteria for having the syndrome. But if you look at those boys and girls who haven't slept very much the night before, it almost doubles. The rate of children who are endorsing patterns of concussion-like symptoms virtually doubles in the presence of insufficient sleep the night before you fill out the questionnaire. That's important for us in our concussion management programs to appreciate that insufficient sleep, which is a big problem, by the way, in Greater Boston, I imagine it is in Greater Toronto as well. Our high school kids are under tremendous pressure, a lot of stress. They're staying up late. They're not getting enough sleep. They're spending way too much time on their devices. They're pushing themselves really hard. They're thinking about their futures and working hard toward them, and they're kind of chronically sleep deprived. And chronic sleep deprivation, I think, in adolescence brings on a lot of concussion-like symptoms. I call them concussion-like because they're not concussion symptoms. They're just symptoms. If you have a youth who's not sleeping enough, who has ADHD, they endorse a lot of symptoms on these questionnaires. So ADHD and LD are important factors to consider for a couple reasons. One is that youth who have ADHD have a greater lifetime history of bodily injury. So they show up in the emergency department at a greater rate than youth who don't have ADHD. They also have a greater lifetime history of head trauma. And individuals who have prior concussions are at statistically increased risk for future concussions. So it stands to reason that ADHD might be an important factor because it confers risk for bodily and head injury, and then once that occurs, concussion history confers risk for future concussion history. I'll show you some data. Here's 33,000 kids from the state of Maine, 14,000 boys, 13,000 girls, about 1,300 self-reported having ADHD and 2,700 self-reported having a learning disability. So we just asked them in a survey, what percentage of you have a lifetime history of concussion? These are the rates. So the control boys, 18.7% of 13 to 18-year-olds in Maine said that they had a history of one or more prior concussion, compared to 26%, 26% of those with ADHD plus LD, or 26% of those with ADHD only. So in boys, and you can see in girls, comparing white to blue and red, the rate of concussion, lifetime history of concussion, is greater in those with ADHD and LD. We don't know when these injuries occurred. We don't know. I'm not suggesting, for example, that a concussion would cause ADHD or an LD. So we don't know the direction of this association. We don't know when they occur. We only know that when you survey them cross-sectionally, they report a greater lifetime history of injury. So now, as we move into predictors of clinical recovery, I want to emphasize one study. It just happens to be the best study in the history of the world on this topic, and happens to be done in this fine country. This pan-Canadian study on predicting persistent symptoms in children. It's absolutely, awesome study. Incredible, and there is going to be a lot of work coming out of this over the next few years as this data continues to be harvested. Here's some of the sites. Some of you in the room might have participated. Roger Zemek in Ottawa was the PI on the study, as most of you know. So this study was running in multiple emergency departments across this fine land for a long time. It was a prospective cohort study where once you got enrolled, you got followed up on a regular basis. The children were between the ages of 5 and 18. They had concussions. They had the concussion within the prior 48 hours. They had to have a GCS of 14 or 15 to be in the study. They could not have a complicated mild TBI. So if they got imaging and if there was anything trauma-related intracranial abnormality, they were not enrolled in the study. They were also excluded if they had multiple significant bodily injuries. So the primary outcome was whether you're endorsing symptoms greater than 28 days. So prior studies would suggest that most kids recover within a week or two, and the literature aggregated would suggest that the vast majority recover within a month. So normally we would think maybe this number is going to be really small. Well, it was not. First, there were 3,000 patients enrolled in this study. 2,500 of them were followed up after 28 days. This is just incredible amount of work. This study is informing the world on this particular cohort of children who present to emergency department. That's an important point we'll get back to. This is a busy slide, but what you can see at the top in white is that roughly 30 to 33% of the total sample was reporting persistent symptoms at 4 weeks. That number is much higher than all prior estimates of good studies. Part of the reason the number is so high is because we're enrolling out of the emergency department. We're not taking all comers. When you take all comers, we would expect that number to be much lower. But this is important. I think these numbers are real and correct. These are the numbers of Canadian children presenting to the emergency department following head trauma who report symptoms more than 30 days. This has major implications for the healthcare system in Canada and the US and around the world, that these kids are having symptoms far longer than we think. And those of us that work in specialty clinics go, oh yeah, that makes sense, but it doesn't really make sense because we know we have a hugely biased sample. This is a biased sample, but not like a specialty clinic sample. This is enrolling kids directly from the emergency department. Now, what you can see in those other numbers is you see a variable, and then you see the percentage. The number represents the percentage of children who are endorsing symptoms after a month, stratified by all those different variables. If you see a star, that means it's statistically significant. If you see 2 stars, it remains a significant predictor of persistent symptoms in a multivariate analysis. So once you consider many variables at once, some of the independent variables drop out, but those with 2 stars hold up in the model. This is probably the most important study, in my view, that's ever been done on this topic. With that said, now I'll present to you what I think is the entire world literature on factors relating to recovery time. A couple caveats before giving you the results. One, no matter what predictor you looked at, the results are mixed. There are virtually no slam dunks here. It's not, oh my gosh, you hear about female sex all the time. Oh my gosh, girls and young women have worse outcome than boys. Wait till you see the data, because you hear people say it, but you don't look at the literature in aggregate, because the literature in aggregate says a different story. Many of the studies looked at outcome only in the first 2 weeks, or even the first week in the literature, and other studies looked out over many weeks. But let's look at age, because we hear this a lot. Age. Younger kids must have worse outcome. Well, this is not the way to do a systematic review, a head count, by the way. This isn't telling you anything about the methodological quality of the studies. I'm just trying to shock you a little bit with what does the literature say in aggregate on whether younger age is associated with worse outcome? And you say, well, it's really mixed. There are actually more studies that say no than yes. What do we think we know in analyzing that? Well, there appears to be a gradient effect that is influenced by multiple variables. One, that high school kids, on average, take longer to recover than college kids who take longer to recover than professionals. There appears to be some evidence to support that, and there's probably multiple reasons for that. A lot of large-scale studies have found no age effects in recovery time, especially some large recent studies that are starting to change our view potentially on this. But then I'll go to this pan-Canadian study from the emergency department, and this is really interesting to me that this adolescent time period was associated with the greatest risk for persistent symptoms across Canada. Female sex. So we hear it all the time. Oh yes, girls, young women, they have worse clinical outcome than boys and young men. Well, here's just a simple visual summary of the literature. And if you're writing a paper, and depending on what you want to say, you can find all kinds of studies to support whatever point you want to make. And you'll see that that's the case for anything you're studying right now in the world of concussion and recovery, that if you're not careful, and hopefully this article is going to be helpful to all of you who are having to write intros and methods to your papers if it has anything to do with recovery, so you don't read a couple of these articles and think you know the answer. Sex differences. Well, there's a comparable number of positive and negative findings. Some large-scale studies, some really good large-scale studies suggest that girls and young women are at increased risk for persistent symptoms lasting greater than a month. I think that's probably true. The full extent of this needs further study, as far as I'm concerned. But I think that although the findings are really mixed, there is a sex difference. Prior concussions. Surely you would think that this would be more lopsided than it is. Look at all the negative findings on prior concussions. I was surprised. I have been involved in this literature for many, many years, reading it and consuming it and writing about it, and doing this review was kind of surprising, a little jarring to me to just do these visual breakdowns of the data. I think prior concussions are important for a number of reasons. They may or may not, in any given study, predict clinical recovery, but individuals with prior concussions report more symptoms on average at baseline. And if you have a prior concussion, you're at statistically increased risk for a future concussion for reasons we don't understand. It's not as simple as a lower threshold. That's what everyone likes to say, oh, once you've had a concussion or two, you have a lower threshold, you're more likely to get them. Maybe that's true. It might have to do with how you play the game. It also might have to do with your genetics. It might have to do with a variety of other factors, not just this lowered threshold concept. And there are, including the study in Canada, there are interesting and important and good studies suggesting that prior concussions are associated with increased risk for persistent symptoms. In the pan-Canadian study, if I remember correctly, one of the most potent predictors was having a prior concussion with a slow recovery. So this is something that hardly anyone has studied in the last 25 years. It might not be just the number of injuries you've had in the past, but it might be the type of injury or the clinical course that you followed in the past that might be a risk factor for persistent symptoms. Health history variables. Mental health comes out as a predictor of persistent symptoms in almost every study. I was surprised on the ADHD because we hear this all the time. Everyone's talking about ADHD, ADHD. In virtually every study, ADHD was not a predictor of recovery time. Now, ADHD is an important developmental variable for you to consider in your clinical practice. These children, on average, might perform more poorly on some cognitive tests. They tend to endorse more symptoms. They tend, by definition, to be impulsive. They are a little bit more injury prone. There's reasons to have concern about individuals with ADHD when it comes to concussion management, but in the literature, individuals with ADHD did not have a prolonged recovery compared to individuals who don't have ADHD. LD, the same thing. Personal history of migraine in almost every study was not an independent predictor of persistent symptoms. I personally think that migraine confers risk. I'm not sure the extent to which that risk has been quantified at this point in time, but I think, for example, the Pan-Canadian study would suggest that a personal and a family history of migraine are risk factors for symptoms lasting more than a month. And there's a very small literature to suggest that migraine is a risk factor, but believe it or not, the majority of studies that have analyzed this have not found it to be associated. Now, this is, to be clear, migraine history, not post-injury migraine. Post-injury migraine is a completely different thing. This is whether you have a personal history of migraine. Is that a potent risk factor for prolonged recovery? It probably is, but we don't have sufficient data to conclude that definitively. Injury severity. So we've been interested in loss of consciousness forever. Some studies suggest it's related to outcome, some don't. Same with post-traumatic amnesia. The one injury severity variable that is most consistently related to outcome is retrograde amnesia in the sporting literature. However, that hasn't been studied that much, and it's been related to outcome in the first 10 days. It hasn't been studied sufficiently to draw conclusions beyond 10 days for retrograde amnesia. Here's the most lopsided literature of all the variables that we analyzed. This is the one you can have the most confidence in from not only a head count or a study count perspective, but also persuasiveness of the literature. It is a little bit of a duh finding, but not really. And that is, the greater your symptoms are in the first 48 to 72 hours, the worse your outcome. So the acute manifestation of a greater burden of symptoms is a reasonably potent predictor of risk for slower recovery. The converse of this is interesting, but has rarely been studied. And I studied it a few years ago and didn't publish it. But we have some unpublished data suggesting that if an athlete presents in the first 72 hours and looks good from a symptom perspective, they have a low burden of symptoms, they have a very high probability of a good clinical course. Also kind of a duh thing, but no one bothers to study these things and write the papers. So to be clear, if you show up this was with high school football data, unpublished, if you show up in the first 72 hours and you have a low burden of symptoms, you're low on the post-concussion scale, you have greater than a 90% chance in the analyses that I ran of being asymptomatic and clinically recovered by 10 days. However, this literature that you're seeing on the board right now would suggest, and does suggest, if you have a high burden of symptoms in the first 72 hours, that is a risk factor for a slower recovery and persistent symptoms lasting more than a month. An argument potentially for early assessment and an argument potentially for earlier intervention. But certainly this has implications for return to school. Acute clinical findings. So in general, the literature is clear that acute clinical findings are a predictor, a reliable predictor of recovery time. Acute and subacute headaches. So when you study headache after the injury, it is related to outcome, without question. So I said when headache is studied as a pre-injury variable, Most of the literature does not find it to be a predictor of recovery time, but when headache is studied in the first few days following injury, then it almost always is a potent predictor of recovery time. Where are we at in terms of a major gap in our knowledge at this point in time? I think that most of the studies, with the exception of the outstanding Pan-Canadian study that I can't stop talking about, most of the studies have been pretty focused and narrow in their approach. They have not adopted a biopsychosocial perspective or a multidimensional perspective. And most studies have focused more on vulnerability factors, and hardly anyone is studying resiliency factors. So I would say resiliency factors are a major current gap in the literature on recovery from concussion in youth. And to try to put it into a picture, you can think about individuals, their genetics, their basic temperament as children, their environment, their learning history. All of those factors can influence their neurobiology, their microstructural neurobiology and their functional neurobiology. The family and social environment can influence microstructural and neurobiological factors. Your brain adapts in different ways depending on how you live and what you're exposed to prior to injury. Then when you get injured, a whole host of things can happen to your neurobiology. And then during that post-injury course, there are many factors to consider that can influence neurobiology and psychology and the whole social context in which that athlete is living and functioning, seeking their health care, returning to school, that sort of thing. So I think we need more biopsychosocial, multidimensional models in sport concussion research these days. Future medicine, future directions. Well, one direction I see us going over the next decade is sort of a precision medicine approach. And we've done a good job in Canada of laying some of the foundation for that by coming up with recommended guidelines for treating persistent symptoms following mild TBI in children, adolescents, and adults. But precision medicine is you're customizing your medical treatments for the unique characteristics of the patient in front of you. And a lot of that foundational work has been done and is reflected in these documents. When I'm trotting around the world, I say if you want guidelines on how to manage persistent symptoms and problems following mild TBI, if you want the best work, in my view, done anywhere in the world, it's right here in Canada, freely available to anyone in the world. Download it from ONF's website and have a chapter devoted to virtually anything you're interested in. This is a wonderful contribution to care in Canada, care in the US, and care around the world. And thank you, ONF, and I would encourage you to continue this work for years to come. Thank you.
Thanks, Grant. That was a fantastic talk. We have time, a few minutes for questions.
You initially showed the Canadian data that seemed to indicate that ADHD and learning disabilities were risk factors for slower recovery. And then at the end, you concluded that they weren't, and I'm a little confused by that.
I'd have to go back and look at the slide. Did it first I didn't have a slide that summarized all the ADHD studies. I used to in this deck. Almost every study done in the past has not found an association between ADHD and recovery time. So one of the exceptions has been this Pan-Canadian study, but I can't actually remember if it did, if it held up in multivariable analyses, for example. Does it have an asterisk?
So it has to have a double asterisk?
So it needs a single asterisk for being a univariate predictor, and it needs a double asterisk for holding up in multivariable analyses. You'll see that individuals with self-reported ADHD, 34% had persistent symptoms at 28 days, compared to in the white up above, the base rate for the entire population was 30 to 33%. So ADHD in this study was not an independent predictor of persistent symptoms at a month.
Thank you.
But it's worth leaving this up because this is like a great summary of predictors. Yes.
Grant, that was great as always. Quick question about your initial thoughts, not going to hold you to it, about what would a resilience agenda look like? Like, how would we start to look into this issue of how people are resilient and not resilient to concussion effects?
I think ONF is going to bring us all together to have this resilience conference, this summit. But as a precursor to that, I would say, one, we are obsessed with looking at poor outcome. And the first step in a resilience line of work is to define good outcome. No one has bothered to define what is good outcome from a mild traumatic brain injury. What is the time course of good outcome? So we need to work on that definition, and then we need to look at variables we're not used to looking at, like how do you measure resilience? How do you define resilience, and then how do you measure that? And to what degree is resilience related to good outcome? Are there genetic factors that are related to good outcome? Good outcome isn't just the absence of bad outcome. Why is it that some individuals with a heavy burden of pathology in their brain seem to do really well in life? Why is it after a moderate to severe TBI, you have one person who you have a heavy burden of pathology, you can see it on structural MR, and they're functioning so much better, psychologically, cognitively, quality of life, return to work, that sort of thing. So it's a big question.
That's great, yes.
Thanks. I think we have to wind it up now. Thank you very much.